Hello and welcome to the Downsized. My name is Laraine Durham and I'm here with my husband, Christopher Durham. Hello, Christopher. And today we have a special guest, Dr. Meghan. Hi, Dr. Meghan.
Hi, thanks so much for having me.
This is our opportunity to talk to the professionals in the field, doctors, pharmacists, you name it, researchers sometimes, a molecular biologist or two occasionally, to get a much more educated conversation around how these medications work, why they work, and just give you some perspective on maybe whether they'd be right for you. We always like to say, and I'm sure Dr. Meghan would say it as well, we're not doctors. Dr. Meghan's a doctor, but she's not your doctor. So please talk to your doctor and make sure you have personalized medicine for you.
Right.
Did I say that right, Meghan?
Absolutely.
Okay. If you haven't already, please like and subscribe, hit that notification bell so you get an alert every time that we publish a video. So let's start out. Tell us about Dr. Meghan.
Oh, thank you so much. I'm delighted to be here. Do you want to hear about my channel or just about my practice, or
either one or both?
all the things? Yeah. So I originally started out in primary care. And I think when you work in primary care, it becomes very clear that you are by default an obesity medicine doctor because so many people's issues stem from weight-related issues. And it just became very clear to me that if you can really treat people's weight, it's a very efficient way of treating them and also preventing things from happening in the future. So I did my boards in lifestyle medicine and obesity medicine. And then I still felt like there was a little bit of a piece missing. So I got certified in life coaching as well. And that really, I think, was the missing piece in terms of helping people make those behavioral changes, because I love the medications and I love helping people change without the medications. But, it is difficult to get people from, where they want to be from where they are to where they want to be. Without the medications, if you don't have a strong kind of plan in terms of how to get them there in terms of the mindset aspect of it. So I work with people in a couple different ways. I work at a academic clinic in Boston. I have my own private practice where I can do everything for people. I can do the life coaching and I can do the medicine part. And then my channel is a place for all things medication and weight-related questions.
And how often are you publishing on the channel now?
I publish 2 videos a week. I do an office hours Ask Me Anything video, and then I do a topic of the week. And then this month I'm doing a YouTube short every day as well.
Wow,
So
how's that going?
So many questions. I was like, let's just get as many done as I can. So yeah.
Shorts are, I've yet to figure out whether shorts have value or not, but we keep trying.
Yeah, they're fun.
Well, perfect. So let's start at the beginning then, because I think it's interesting that you realized you were an obesity doctor, whether you wanted to be or not, right? Mm-hmm. So it just kind of was the beginning of it. Help us understand obesity as a disease and how it impacts people.
Yeah, I think we talk about obesity as this kind of monolith, but there are so many different reasons why people are obese. There are genetic reasons, there are social reasons, there are medication-based reasons. I see that a lot in my clinic. There's environmental reasons, people who have grown up eating a certain way, they don't know anything differently. So I think, from my perspective, it's very heterogeneous in terms of how people get to a BMI that they're not happy with and we feel like isn't healthy for them. Mm-hmm. And some people had never had a problem with their weight until they, had a big life event. And then all of a sudden everything went off the rails. And some people have had an issue since they were, in high school or earlier. So it's really, there's a lot of different ways that people have problems with their weight.
So it's an interesting conversation because, it seems like there's always been a boogeyman around weight, whether it was fat or cholesterol, or today it's everybody thinks processed foods have caused it. And there's not one thing that's doing that then?
I mean, I certainly don't think that our culture helps very much. Mm-hmm. I think there's a big, we have kind of an all or nothing culture. We have, the very processed caloric foods. And we have this culture that wants us to get our value for our money and wants us to be very productive and multitask and do all the things. And all of those things aren't very helpful in terms of getting somebody to just sit down and pay attention to what they're eating. So I think that the convenience factor is a big one. And then I think there's kind of the total other side of the spectrum where everything gets very like science-y and counting the macros and the calories. And I think that's pretty exhausting for people. And I always think like the changes you want to make are changes you should be able to do into your 80s. So if you feel like you're making these changes, but it's a lot of work, then I don't think it's going to be very sustainable. And what we do know from the literature, which is kind of all over the place in terms of what diets work, but what we do know is what really works is if people can stick with the changes that they're making.
Yeah. So thinking about, macros and calories, do you suggest to your patients any specific meal plans to follow with GLP-1s, any calorie guides, any food tracking that you had them do?
Yeah, I might be a little different because I don't. What I really like about the GLP-1s is that they really strengthen that message from your stomach to your brain. And so I really want people to listen to their internal cues as much as possible, because that's how we evolved. That's how we, when you're a little kid and you're, eating when you're hungry and you're stopping when you're full, like that's how we're built.
Yeah.
And so I think these medications kind of help correct us back to that. And so I really want people to just listen to their body. And certainly, people's appetites are really suppressed or they're just starting the medication. There's definitely a time and a place for being a little bit more prescriptive about it.
Mhm.
But I would much rather have somebody listen to their body, get 5 servings of fruits and vegetables a day, make half their plate produce. Like those are the things. And it's very boring. It's not very exciting to do that. But those are the things that I really want people to focus on. And, it's really hard for people to do that.
It's hard to get those vegetables in. Like,
Yeah.
really 5 fruit? Yeah, like, I mean, am I eating vegetables for breakfast? Like, that's a lot of vegetables, right? So it's
Right.
really something I've had to focus on in the past, like to get all those things in. Do you have protein guidelines that you give your GLP-1 patients?
I do. Yeah. So I say, about 1 to 1.2 grams of protein per kilogram ideal body weight. So if somebody wants to get
Ideal.
to 150 pounds, let's say, we would
Yeah.
work from that number. But I never want people to eat protein at the expense of their appetite. So I don't want people just like, oh, I got to get those last 20 grams of protein, but I'm really stuffed. I would much rather have people like listen to their body, stop when they're full, and maybe, try again the next day or move things around a little bit. And I think this is another area where like ChatGPT is your best friend. Like it's so nice for people to just, if you like, because I'm a big fan of plant-based proteins. I don't want people to have a lot of cholesterol issues when they're trying to get their protein. And certainly I think there's, I don't tell people they need to be vegan or anything like that. But I think incorporating different plant-based proteins is a great way. And then you don't have to worry so much about, heart disease risk or things like that.
So thinking about plant-based proteins, what are like tofu? What are some of your go-to plant-based proteins?
Yeah. I mean, tofu and tempeh are always great, but a lot of people have this like immediate resistance to tofu, which I get. It's like sort of tasteless if you haven't worked with it before.
It'll take on any flavor you give it. It doesn't matter.
Right.
Well,
I love it. I think it's
yeah.
great, but
Yeah.
not everybody does. So I really love edamame. I think that's great. You can freeze that, keep it in there, and then just take it out whenever you want. And the thing about edamame is it has a nice kind of starchy texture. So it gives you kind of a different like mouthfeel.
Right. Like I'm eating a carb or something.
Yes, exactly. Like you're eating a carb, but it's not quite a carb, but it's, but it has a lot more protein than you would expect. And I like quinoa a lot as well. I think that's a really good one.
Quinoa. Yeah, we've done some quinoa.
Yeah, quinoa. And the edamame and garbanzo beans, you can crisp up in an air fryer and get it crunchy too.
Oh, yeah. Yeah, exactly. There's so many things you can do with it.
Because I like crunchy textures. It all
Yeah.
gets mushy. I don't like it.
Yeah, absolutely.
So, you talked about maybe cholesterol, the foods that might lead you down a path, I guess maybe the keto diet or so do you steer people away from red meat? What's your feeling on that?
I don't. I mean, I think if somebody's having steak every night, I'd be a little like, oh, like I'm a little worried.
Yeah.
I think there's a plate, like if somebody really, my dad is from the Midwest and he like, you gonna pry the meat out of his cold dead hands,
Yeah.
right? Like it's just not gonna happen. So I think it's really about like knowing yourself. And then it's also about like knowing what's healthy for you.
Mhm.
And so I think if somebody really loves red meat, it's important to think about, okay, like how can I do this in a way that's a bit more intentional? Maybe I don't want to have red meat every night. Maybe I want to have it once every week, once every 2 weeks, keep it on my cholesterol, see how things go. But again, I think it's all about like really knowing yourself and what foods are important, because I think there is a way to eat bread and be healthy, cookies and be healthy, red meat and be healthy, but it's about being really intentional about it.
Well, so you had a video the other day about foods you shouldn't be eating. Tell
Yeah.
us about that.
So that was, oh gosh, I think that was just a list of my pet peeve foods, but um, I think, I don't love processed foods. I definitely think, if people are going to have things like cookies, like get a really good cookie, like
Mhm.
make it count, get the best cookie you can or make it at
Yeah.
home,
Yeah.
right? But a cookie that can last on a shelf for 5 years, like it's probably not going to taste very good either.
Yeah, I agree with that.
And yeah, and I think we're still learning about all the additives, but we can probably guess that they're not great for us. Um, and then other things like, I feel like there's a lot of tricky things that happen to yogurt, you know.
Dessert. Yeah.
Right, right. It's just, and I have a lot of people that tell me, we're going through what they ate and they're telling me that they're eating yogurt. And I'm always like, hold on, what type of yogurt is this? Because I just want people to be aware, one, if it's actually yogurt or if it's like yogurt-ish, like they
Yeah.
took all the fat out, they put a lot of stevia in, like I just want people to be aware of what they're eating.
Yeah.
We did a review video and we tasted like 14 yogurts.
Yeah.
And it was really interesting, the differences in the sugars and the protein. One of them was it with the yogurts, but it was labeled
But it couldn't even legally be called yogurt.
It wasn't really even yogurt. We're like, what is this stuff?
Right.
So
Right.
yeah, no, we get it. We're with you on that one. What's your feeling on protein powders, protein shakes?
Those don't grow on trees.
They don't grow on trees. I think there's a time and a place for them for sure.
Mhm.
I think whenever we're, drinking calories, there's always kind of probably a window where you're not feeling as satiated as you would if you were eating solid food that has fiber in it. Um, so I think if people rely on them a lot, and then we're talking about like why they can't lose that extra 5 to 10 pounds, like that's a great place to investigate things.
Mhm.
But I think certainly for people, especially in the early stages of when they start the medication, they can be really helpful. I don't want anybody to get malnourished on the medication.
Yeah.
And so I think there's a time and a place. I would say like sporadic use. Yeah.
Okay. All right. I was thinking about what you said at the beginning about tuning into your hunger cues and eating to that. So I know when we first started our GLP-1s, appetite totally suppressed, no hunger. I could eat like 5 bites and can't eat anymore. And now we're about a year and a half into this. And Christopher's in maintenance. I've been in maintenance for about 6 months, and I feel hungry at meal times. Like I feel those hunger signals. I don't know if they're starting to come back. I don't know. I have decreased my medicine dosage because at first I thought you were supposed to.
Mm.
So do you think, if you're not feeling hunger signals, are you too suppressed?
Girl, there's like 5 questions.
There's a lot.
in there.
I have so many questions.
Okay.
So many questions. So when is it appropriate to feel hunger on a GLP-1 medication? I guess is my question.
Yeah, I mean, ideally, people are feeling hunger the whole way through, but there definitely are those times when people start, or if they're going up on the dose, where it is very suppressed. And so when people are at that stage, I usually say, well, let's take a pause on like feeling your hunger because you're not feeling it at all. So we
Yeah.
have to kind of go through the motions with eating, like have a breakfast, lunch, and dinner, have a couple bites, make
Yeah.
sure everything's staying down. That's a good place for protein shakes too sometimes.
Mhm.
But yeah, ideally people are getting more used to kind of normal patterns of hunger. And I think the really important thing about, getting in touch with your true kind of stomach hunger is
Mhm.
that you're able to separate out the mind hunger. And
Right.
I feel like that's very confusing for a lot of people, especially if they're not on a GLP-1, because our mind hunger is always on as this kind of evolutionary advantage, right? Just like eat
Right.
whatever looks good.
Keep you
But it's very
alive.
different from our stomach hunger.
Yeah. I guess on previous diets growing up, trying every fad diet, Weight
Mhm.
Watchers, all the things, I always felt like hunger was the enemy. I didn't
Mhm.
want to feel hungry
Yeah.
because that led to overeating. So I think I've, really been trying to not feel it for so long that now when I do feel it, it kind of makes me panic a little bit. And it's not so much the mind hunger,
Mhm.
but it's the stomach growling. It's like, "Oh, it's mealtime. I'm hungry. Is that okay?" Like I have to reset my expectations. Does that make sense?
That makes total sense. Yeah.
Yeah.
I think we have a lot of hunger panic in our culture.
Panic,
Of like,
yes.
you shouldn't be hungry because there's this idea that like you're just going to overeat or like you're going to pass out. But like most people are not, like if you're hydrated and you're not, you don't have an eating disorder or a pancreatic issue, like most people just feel hungry and then it kind of comes in waves. And it is a very normal, human feeling. But
Yeah,
I think we've gotten really used to, you should never feel hungry. This
right.
is going to trick your body into thinking that you're starving. And then it's so interesting because over the last few years, there's this, intermittent fasting
Yeah.
now. And so there's this other camp of
Well,
people that are
those
like,
people come for us all the time. So
oh, do they?
I
They're like,
can't
it's fine
intermittent.
to be hungry.
Hmm.
So I think it's so interesting. I don't think there's a right answer, but I do think, I think the hunger panic is, also an evolutionary advantage. But I also think that we have to remind ourselves, like, if I'm in my car and I'm hungry, I don't need to eat in my car. Like, I'm going to get to where I need to go and I'll eat when I get there and it'll be fine. And I think we
Yeah.
don't really talk ourselves through that much.
And I think the GLP-1s have kind of helped with that because
Mhm.
my hunger, the food noise has dialed way down or even off. And so I don't have that food, need food now. And if I'm actually hungry, I don't have to eat right at 6 o'clock. I don't have to, what? I know that if I
Mhm.
have to wait a little bit longer for food, my mind will not go into a panic.
Right.
That's really helped. The GLP-1s have really, I guess, helped me
Yeah.
in that respect. So,
That's
yeah,
great. I mean, that's really what you want is that you're able to self-regulate your, how you're reacting to your body's hunger.
yeah,
Well,
yeah,
so the $100,000 question on this is always that sort of long-term question, right? Of obviously the GLP-1s are impacting not only the way we digest things and the satiety and all that, but our brains.
Mhm.
So how much of this, and I don't think anybody knows the answer, but maybe you do, how much of this, because we've now done it a year and a half, through sheer repetitiveness are we learning and we can continue versus how much would go away if I stopped?
mm,
Mm, yeah. So we do have, a small small body of evidence. Of course, this is, I always have to remind myself, like, we're at the very beginning of this enormous branch of medicine. And you can just imagine where we're going to be in, 10 to 20 years from now. So there's not a lot of data, but there's some good studies. There's a SURMOUNT-4 study where they kind of took people, which I'm sure you're familiar with. They took people off medication and they did a placebo, and then they watched people, kind of the weight gradually comes back on. And there was about 15% of people that the weight didn't come back on. But I always tell people, where we are right now, there's a very, very good chance that you would regain the weight. And who knows what we'll have in 5 years from now. Those I know, the goal of the pharmaceutical companies is really to, stretch this out as much as possible, so people could have like a once a month injection or a once a year injection, things like that. So we're definitely moving in that direction, but I would not tell anybody to go off of it right now.
So we're both in maintenance, and I've watched you've talked about maintenance in a couple of videos. So talk to me about your thoughts around that.
Yeah, I mean, for me, usually I will just keep people at the dose. If somebody's on tirzepatide, I'll keep them on, and they're on 15, I'll just keep them there, unless they're having a lot of significant side effects, because, the medications are dose dependent. But I think a lot of people are kind of like tinkering around with it. And I don't have a huge problem with that, because I think, again, this is also new. And who knows what we're going to find out. And so if people go down a little bit and want to watch it, I'm okay with that. I think the key for maintenance is just, it's probably going to be kind of boring, which is good, right? I always want people to be medically boring.
Yeah.
Some people's, I don't want people to have a lot of drama about their food or drama about their weight. I want them to be able to think about other things and do other things. And I don't want their mind to be so cluttered with food.
I think for most people right now, the drama's around cost and insurance and all the peripheral stuff that gets in the way of the healthcare.
Yeah, absolutely.
Have you seen anyone on 15 in maintenance where the drug stops working, becomes less effective? They get so used to it that is there a danger of any? I know it's so new.
Yeah.
I was just wondering if you've encountered that.
No, I haven't. What I have had people come in and say it stopped working.
Oh.
And they gained like 5 or 10 pounds. But this has happened every single time. When we do a deep dive into what's going on with them, like they stopped working out, there was like a family emergency, all the lifestyle things have changed. And so, and usually then when they kind of get back on track with those, like they'll go back to where their baseline was. And of course, like when you're at your new normal, it's going to fluctuate just like anything else. So it's not going to be exactly the same number every single day.
Yeah.
Yeah, I have had a couple people come in with that, but there's always something else going on.
There's something. It's kind of like a plateau. Like, are you really at a plateau, or did something else change in your lifestyle?
Go ahead. So, and I've been on 15. I'm at the highest dose now for 5 months or something. So, and honestly, I'm perfectly happy with it. I don't have side effects really at all. It's still the medication. So about every other random Tuesday, I'll feel something weird, but it's not bad. It's just like, I don't know why I'm tired today. Well, it's the shot. It just is.
Right.
That's funny. So, I mean, but we get people all the time that are like, it stopped working. Like, did it?
Yeah. Yeah. And I think it's very easy. Like, it's very easy for our brains to just like kind of overgeneralize. And, a lot of times it's much easier for us to do that than to like really keep track. It's a lot more work for your brain to like keep track of all the things that you're doing. Like, okay, this week, how many times did I like eat the way I wanted to eat? How many times did I work out? Like, did I cut my workout short? Was I sick a week ago? Like, when people get really nitty gritty, it's more work, but there's a lot more. It's a lot more help.
We tell people that all, and Lorraine's got spreadsheets on spreadsheets. And I'm like, anytime where I went up over the last 79 weeks, I can look back and tell you why I did.
Yeah.
It's not, we were on a cruise, it was
Mhm.
Christmas, it was whatever the reason was. And just as soon as we got back through and kind of just got into normal life and did the things we were supposed to be doing, it was fine. It came off.
Mm-hmm.
Yeah, absolutely. I think that's such a good perspective too, because it's very easy to go into like, it's not working, and then like the alarms start going off.
The downward
Oh, I had a
spiral.
lady the other day call me. I'm like, well, how'd you get my number, first of all? Second, she's like, my Eli Lilly's that pound, it's water. They're sending me. I'm like, what are you talking about? It's not. That's not right. So let's
Right. Right.
Well, and I think a lot of people, I use compounded medication throughout, compounded tirzepatide, and I think there's a lot of fear around, if that goes away, when that goes away,
Yeah.
what's going to happen and what should I do, because I can't afford, the name brand. So, that's a lot of fear around, really, is it working, and really, do I need it? And, I think people are really having a hard time with all those questions right now.
Yeah, I think that's such a good point, because about half of the US population would qualify for these medications.
Yeah.
And the cost as it is so, like, this could like tank the insurance industry. Like, I understand kind of like I don't like it, but I do understand why they're kind of pushing back aggressively,
Sure.
because these are forever and the cost is, really prohibitive. So yeah, I think there's a lot of, administrative things that need to change for people. And also because it's so, you're preventing so many things from happening. It's just it's a lifesaver for so many people.
Yeah, we agree.
Well, so as you look at your practice, what are the myths that you hear? I mean, what are the things that you have to talk to people about every day that you're like, no, you're not going to go blind. No, you're
Yeah.
whatever.
Yeah. I think the top one is like, do I need to be on this forever? And that's the big one. And then a lot of people, I have to kind of hammer it home. Like, there's other things, like, we can't forget about lifestyle. We need to, also, and I think the medications are very helpful for some people. They really prompt them to have their tastes change a lot, but not everybody does. And I definitely have some people who, like, they kind of eat the same way and they lose weight, but I'm like, this could be a lot better for you. This could be working a lot better if we made some changes, or, going to the gym. A lot of people they've never gone to the gym before. They don't know how to strength train. And that's always a little bit of a road bump for people too, if that's brand new for them.
How important is strength training on a GLP-1?
I think it's really important. You're always any kind of weight loss you have, a small percentage of that is going to be muscle. I'm definitely not, I give this to patients in their 70s and their 80s. I'm not seeing anybody come in with like frailty muscle. Like, that's not happening for me from what I've seen. But, it is, there is going to be some muscle loss no matter how you lose weight. And so, especially if you're losing it faster, and especially even without the medications, as we all get older, it's really important to build that muscle so you can get out of a chair, so you can get out of bed, all these things that really contribute to your quality of life as you get older, and keep you independent.
Yeah.
Well, so it's interesting you haven't seen any frailty. So I'm curious, and there's so little research around a lot of this stuff. Yeah, you're 100 pounds, 200 pounds overweight. Inevitably, you're going to lose some muscle in that. It's just going to happen. As you look at that, though, what should be the goal for the muscle, right? So if I'm 400 pounds and I've got X amount of muscle and X amount of fat, and I'm 200 pounds, well, obviously, I don't need the same amount of muscle to carry 200 pounds versus 400 pounds. So what am I targeting?
Oh gosh, that's such a good question.
Sorry.
I don't, I'm not with patients always doing like a DEXA scan for them. I mean, I wish I could, but they're pretty expensive for people. So I can do that in my private practice. but not as much in my hospital-based clinic
Right.
practice. Gosh, I'd really
I mean,
have
because
to
I
think
talked to a
about
guy the other day. He's like, I want to get back to the muscle I had when I was 400 pounds. I'm like, I'm not a doctor, but I'm not sure you need that. I think you need
Right.
the best for you right now, not the best for what you were.
Well, I guess there's some point
Yeah.
where you have a percent of muscle, percent of body fat that would be based on your height, weight, age, all that kind of metric.
Yeah. I mean, a lot of people ask, like, what should my weight be? What should my BMI be? Like, they really
Yeah.
want to know. And I always like to think about somebody's weight history. Like, what did you weigh in high school? What were you in your 20s? Like, what does that trajectory look like? Because some people are just more kind of muscularly dense. And so they've always been on kind of like a higher weight, even though they were athletic and fit, and the scale just read higher. And some people aren't.
Well,
But
and that's the dirty little secret of BMI, right? It doesn't consider
Right.
anything but height and weight. So,
right. So it doesn't tell you. So that's why I like to look at, somebody's personal history. And I think it's also helpful too, because if somebody says that they want to be, 30 pounds below where they were in their like high school or 20s, it's like, okay, well, I don't know if your body wants to do that, but we can talk about it. So,
well, and even some of my, 40 something or 50 something year old friends want to get back to their weight when they were 17. And I'm like, I don't I don't know that that's healthy or, realistic. And so they keep going, trying to achieve, a really low number. So, I don't know.
Yeah.
But for me, growing up, I was athletic. I was overweight and always, given a hard time by my parents about losing weight. So, you say, what did you weigh in high school? I probably weighed 220 in high school, right?
Yeah.
So, and now I weigh 140. So I've never been this weight before.
Yeah.
And I'm not sure I could go lower. Am I, you know what I mean? Like,
Yeah.
I'm not sure where to stop, I guess. I mean, I feel like I have stopped, but sometimes that little voice in my head says, well, maybe you get to 130, maybe you get to 125, I don't. So it's just hard to know where is that best weight.
Yeah, I think, sometimes we put so much meaning on this number.
Yes.
And I find that the closer we get to that kind of goal range, the less important that number is to me, just from a health perspective, because what I really care about is, as we're getting somebody's weight down, is how are they feeling? How are they eating? How are they, are all the other lifestyle things in place? And yes, there certainly are going to be those people that they've had a weight, their weight has been high since they were in high school or since elementary school. So this is very new for them.
Yeah.
And so that's where I also like to bring in things like, if people can do it, like a DEXA scan or things like that, because it just gives you a little bit more, like your percent body fat. You just get other numbers. And I think we're so used to being like, well, 120 or 130 is a good number. And I really try to get people to detach a little bit. I think the weight it is important for tracking purposes, but we want to try to be as objective as possible.
Yeah, we have one of those scales that measures, body fat percent and water. So I do like looking at the other data points to kind of like to try to detach a little bit, not let that one number ruin my day or, whatever. Right. So it's still a struggle, though. I think
now she gets bent out of shape about the metabolic age on it.
Oh, so. Yeah. Now it's saying I'm a year older than my actual age. I'm like, all my other numbers are in the green. Why is this one out of whack? And then I'm like, it's a stupid scale app. Like, I can't.
I know. Sometimes the scales give people like a letter grade too. And I really hate that. It's like, you got a B minus. Like, that's so not helpful.
Oh, I would die. If mine wasn't an A, I would would not go well for me.
I know.
And see, for me,
Right.
all of my numbers are green except BMI, and I'd have to lose another 10 pounds to get to a healthy BMI. And I'm like, I'm 186 pounds. I'm fine. Move on.
Yeah.
Right, right. Yeah. Yes, this is definitely when people get close to their goal. It's like, we detach a little bit and
Yeah.
focus on the whole picture.
Well, so we get lots of questions. There's after people have been on these medications for a while, there's a lot of things around stalls and plateaus and what am I going to do? What's your thought process around that?
Yeah, I think nobody's gonna lose weight in a perfect, downward trajectory.
Mm-hmm.
And I think just, everybody wants to lose weight. Not everybody, but most people want to lose weight immediately
Oh, yeah.
and, get to that number very fast. And I always try to tell people like that, first of all, it's not possible. And second of all, you'd be very miserable. You don't want to do that. And your gallbladder would not like that. Your skin would not like that. So I find that people usually plateau at a dose or two along the way. And I think it's always important to just always do a check on how the other things are going. Is the sleep still happening? Is the exercise still happening? Is everything else the same? And I usually don't get too bent out of shape over it because I know like people just respond, like they'll plateau at one dose and then they'll lose, 5 pounds on the next dose. And, I've seen this enough so that it doesn't worry me. So I think a lot of it is just helping people have the big picture in mind.
Mm-hmm.
But also, you always want to make sure like they didn't start a medication, that could interfere with it or things like
Yeah.
that.
Do you move people up through the doses, monthly, or do you leave them on the lower dose until they plateau and then move up? What's your feeling on that?
It always depends on how somebody's doing. Because as you know, I'm always impressed by how variable the response is to this medication, way more so than most other medications that I prescribe. So, nobody has this sort of variability on like blood pressure medications. So, typically my goal is to move people up every month, but it probably happens that way like 50% of the time because of course people are having side effects or some people just aren't comfortable. They're just like, I just want to stay here for another month and see what happens and see if the weight, if somebody's losing a lot of weight, I won't move them up fast.
Mm-hmm.
So I always just think, you're not going to care in 3 years, how fast you went through this. You'll just care about your experience,
Yeah.
and how sustainable it was for you. So I try not to be too formulaic. I mean, my plan is always to have people get to the highest dose if they can tolerate that, but I'm not too rigid about it.
Gotcha.
Well, so I'm curious because we get lots of people, and I'm sure you know this, that have had bad doctor experiences. Doctor wasn't informed, the doctor wasn't kind, the doctor, whatever, right? Not pointing fingers at anybody. What advice would you give people as they look for doctors and kind of talk to their doctors about this sorts of things?
Yeah, I would say that definitely, it's great to advocate for yourself. And I think in terms of primary care doctors, everybody's a little bit, every doctor is going to be different. So there are going to be some doctors who are really comfortable with this. Like I have doctors in my practice who, they pretty much do all the prescribing on their own and they'll only refer to me if there's a really big issue or they're running into a wall with something. And then I have other doctors in the practice that they'll always refer to me because they're not comfortable with it or their practice is so busy and so I think there's just to be aware that not every doctor is going to have the same comfort level with it. And you do really want somebody who has done this a lot because there is a lot of variability and you do need to be monitored. So I always just recommend, if your primary care doctor is not comfortable with it, check out the American Board of Obesity Medicine. There's a directory there. There's so many doctors getting certified every year. It's really a growing field. And so there should be somebody in their state that can talk to them about that, who is very knowledgeable. And yeah, I mean, weight is a sensitive topic for people, of course. So you want to be with somebody who's going to monitor you and also you feel like you have a good rapport with.
That's interesting, from the doctor's perspective, that the doctor isn't comfortable with it and they'd rather pass it along to an expert such as yourself. I guess as patients, we don't really think of the doctors as maybe not being knowledgeable in something or not wanting to, touch on hard subjects. You know what I mean? Like, I guess from a patient's point of view, we hear a lot of, well, my doctor said GLP-1s, he wouldn't prescribe to me. So what do I do? And most of the time our response is, well, you could look for another doctor.
Mhm.
And then, the next thing is, well, how do I do that? So it's nice to know that you could go look at an obesity specialist up online and find that information too.
Yeah, absolutely. And I think, with primary care, you're dealing with everything. And so
Yeah.
some people, are very comfortable with it. And some people are, it would be like referring to any other specialist. You're like,
Yeah. And why wouldn't it be? Like what you know what I mean? Like, we put all this emotional attachment to weight, right? If the doctor mentions it, we get upset. If they don't mention it, we get upset.
Yeah.
You know what I mean?
Yeah.
So, it's important to advocate for yourself for sure.
Just know on any number of occasions I've had to tell people, I know this is hard and it's hard to talk to, but you should have a primary care physician who you can look in the eye and will look you in the eye and you can have a real conversation about whatever your health problems is or are. And if you don't, find another one.
Right. Yeah. 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 You have to be able to talk to them about uncomfortable things. I'm always, that's the bizarre part of my job, I think, is like I meet somebody and then immediately start asking them the most personal questions. And that's just kind of how it is.
Yeah.
I mean, because I know I started these and I think my doctor, he's an internist, great guy, sit down and talk to me, but I think he had maybe written 3 or 4 prescriptions for it when he first wrote the first, but he told me that he's like, listen, I can refer you to somebody, but we can figure this out and we can do blood work as often as possible. And we can, and I'm like, let's try it. Let's see,
Yeah. And I think that's very fair, especially as these new medications come out there. I mean, there's going to be a point where like nobody's kind of done this before. Right. And so we're all on the same page as long as everybody's aware that like, this is my level of comfort with it. And, how do you feel about that as a patient?
So looping back to the stalls and the plateaus. So there's all these tips and tricks online, right? Move your shot, eat something different. Do any of those things? Is there any efficacy to any of that stuff or?
I've definitely heard people when they move the injection site that anecdotally that does seem to help some people. I'm always checking, like what are people doing when they're eating? Everybody's like scrolling on their phone, on the computer, working. And I'm just like, I do feel like that's another place where you're missing that window of these signals coming from the stomach and you might be missing it because you're, not giving it your full attention. So that I'll always check with people about. Yeah. Are people stopping when they're full? Did they fall off the exercise bandwagon? Is it the holidays? Yeah. I mean, I think, and some people think they're at a plateau, but that's just where the medication is going to take them. So some people, and I'll go through, I'll calculate their total body weight lost because some people will say, I've hit a plateau. It's like you lost 16% of your body weight. This is like on, Wegovy. And so I'll just tell them, this is actually more than we would expect. So it's not a plateau. It's just, this is probably as far as the medication is going to get you. And so now if we want to get your BMI lower, we have to add something else.
Well, that's an interesting point. It's taken you as low as it's going to get you.
Yeah.
What kinds of things would you add for someone at that point?
So if I had somebody and, they got from like a BMI of 38 to 31, and we want to see if we can get them closer to, into the 20s. I'll always, my go-to is always, how are we feeling about the lifestyle changes? Is everything kind of dialed in exactly how you want it to be? And that's always my go-to next. Because I do, I really believe that people can make significant changes. And I think a lot of it is just this kind of identity shift that people have to have. I think it's easier to make that shift when you can see the numbers going down in a way where if you've been yo-yo dieting a lot or trying a lot of different things, you're used to it not staying there.
Right.
So I really believe that people can do that. And then I'll think about adding something like phentermine or Qsymia or Contrave. Those are okay, but they do have more side effects. They don't always play as nicely with other medications. So, but they're certainly an option for people too.
Do you ever move people from Wegovy to Zepbound when they hit a point like that?
Yes, I will. Actually, I just had a patient last week. She lost about 11% total body weight. So she was pretty close, but I just felt like it's worth seeing if she could get further with tirzepatide. So I will definitely.
And I guess you wouldn't start them on the lowest dose of tirzepatide. You'd probably figure out an equivalent.
Yeah, that's always a little bit tricky.
Yeah.
So I tell people like this, you might not see a difference for a while, because I think if I change you to the 15, that's kind of going to blast you.
Yeah.
And I don't want that. And if we start at the 2, you might gain some weight. Every once in a while, if someone's had a lot of side effects, I will start them at the 2, but usually about 7.5 or 10.
One of those.
More recently, I've been doing the 7.5 because even the 10 is pretty strong for some people.
It's a lot of GIP all at once.
It sure is. It sure is.
Yeah. And people ask us that too. A lot of people want to switch from one to the other. And is there any benefit to it? Especially if you have a lot of weight to lose. We've seen people lose 100 pounds on one, but they still want to lose another 50 to 100 more. So, it's an interesting thing to think about. Have you ever seen anybody go from Zepbound to Wegovy?
I have. Not as much. Not as much, but I have had people do that. But that's more of like a side effect profile, never usually for a weight.
I mean, people will ask, and I'm like, first of all, not a doctor. Second, talk to your doctor and your insurance and see which one it'll cover, because that's the one you want to start with.
Right. Start exactly. For sure.
Yeah. That's your biggest side effect is your insurance company. Absolutely.
Yeah.
The one you get for $25 is the best one, right?
That is so true. That is very true. Absolutely.
So our insurance covers no weight loss medication. So, we're just trying to figure out,
which honestly in maintenance, that's the biggest, the biggest reason for me to even look at going down is not because I'm having a problem with it. It's fine. But if I could go down to 10, I could get the vials and from Lilly and it would
be cheaper,
be
a lot cheaper.
Right.
Well, now on the 10, if you can get to the 5, that's where it'd be a couple $100 cheaper.
Right.
But, and if the coupon goes away, there's just all the things. There's all the things that go on.
I keep hoping I'm delighted that they've rolled that out and that the prices keep coming down. And I hope that, as their new medications come out, that things will get more affordable and we'll have some like market correction somewhat.
Yeah.
But it's very obstructive for people.
Yeah.
Well, so as you look at those new medications, there's a bunch coming, right? But certainly the big ones are orforglipron, CagriSema, retatrutide. Is there anything you're excited about there?
I think the retatrutide is really exciting. That is, that would be great. I mean, we're just kind of keep moving the needle in terms of results for people. So, but I'm keeping my eye on all of them. I think CagriSema, the weight loss seems to be about the same as what people are getting now, but it's, might be more tolerable for people and slightly different mechanisms. So that would be really nice. But yeah, I think it's really exciting. All the research and development going into it, and there's going to be so much. So that's why I feel like if people are like, I don't want to be on something forever, I just want to tell them like, don't worry, because there's so much that's going to change that who knows what it's going to look like.
Forever looks completely different a year or 2 years from now. I mean, there's like 15 or 16 orals in development. Certainly that's going to bring prices down.
Right. Yeah.
Well,
that would be really revolutionary.
We were with some friends yesterday, and I was talking to one of the older ladies, and she goes, I would love to try it, but I can't do anything with a needle. I can't do anything. I can't take a shot. I can't do anything with the needle. I said, well, there is a pill coming out in a couple of years. So she goes, okay, I'll just wait for that. And I'm like,
I always tell people, I'm like, let's get over the needle phobia.
I had to, right? Yeah. I've done 78 shots now, but those first 5, my husband had to give me because it was terrifying. It really was. But once you do it enough, I mean, now it's not a big deal at all.
Yeah. But that's so great for people to know too, though. I think that's the benefit of being able to watch you both go through this, is you're kind of the real time up and downs and what you're experiencing, and the getting over the needle phobia is really helpful because, and I also, I have little demo pens and I'll show them. I'm like, if you're not doing the vials, if you're doing the pen, it's really easy.
The scariest part of the pen is the click, honestly.
Right.
The noise is scarier than the needle.
Right. Yes, absolutely. So it's definitely worth it. I try to push people in that direction.
Yeah.
I don't know. I think the next 5 years, this will all look completely different, and you'll have so many options to customize medicine and help people that it'll be crazy.
Yeah. Yeah. And hopefully much more affordable. And I mean, there's always, every time something new comes out, I'm excited. And then I'm also like, oh no, then everybody calls and they're like, I want to switch to this one. And then I'm like, then there's going to be. So hopefully, the pharmaceutical companies are preparing. I don't think you could have prepared for the kind of Wegovy shortage onslaught that happened, but I think, they did better with Zepbound, and hopefully it'll,
Well, so we live in North Carolina, about 15 miles from the Lilly plant, and it's this huge, just sprawling factory.
Wow.
That honestly, I kind of wonder if they're going to be stuck with a big factory they don't need 3 years from now. But
oh my gosh, I know. Yeah.
Oh well, it's life.
Oh well.
Well, so as you look at our healthcare system, it is so complex and so expensive. As you look at the future of it, I mean, how should it change? What should be different?
Yeah, I mean, I'm just really hoping that this is me being so optimistic, but I'm just hoping that as everybody is on these medications and changing their lifestyle, that is passed on to kids, because what I don't want is for, the generations of, like, the American lifestyle is, you grow up, you gain weight, you go on one of these medications, like, I think these are great tools that we have to push back against a culture that is really not as invested in keeping us healthy as other places in the world. So I really hope that this is an opportunity for us to change how we're how we're living at home and how we're teaching that to our kids.
I mean, I can tell you the food we buy, the things we are all completely different than they were.
Right. Exactly.
Yeah.
Right. And that makes such a big difference in terms of, what your friends see you eating, what your kids see you eating. So it's really such a big shift. And I hope that, I'm so glad that these medications, that we have them. But I also, I think we all wish that we didn't need them, right?
Of course.
Right. Well, if that were the case, I would have lost the weight and kept it off years ago, right?
Right.
So, but yeah, it's definitely been life-changing, for us, for sure.
Right. So I hope all that happens, but I think it's, it's really nice to be able to maybe also be kind of reversing this trend of obesity and getting people to a safer place in terms of their BMI and the chronic medical conditions, and and just helping people be more active. It's a lot easier to be active when you don't, you know, you don't have as many joint pains, or you're,
Right.
you know,
Easier to walk around and easier to move, and, you know,
yeah,
play
exactly.
pickleball.
Right. Exactly. Absolutely.
Now it's all pickleball injuries.
Yeah.
Okay. Right.
Yeah.
Well, so tell us, if people wanted to say, "Oh, Dr. Megan's cool. I'd like for her to be my life coach or my doctor." How can they do that?
Oh, absolutely. So they can go to my website. It's www.weightmedicinemd.com. And I meet with people to see if, you know, it's going to be a good fit. We'll talk about what's going on for them. It's very low key. And then they can also check out my channel as well, because I love talking about all things weight related all the time.
Well, I think it's exciting,
Awesome.
and you were popping up all over my YouTube, and I was like, I'm gonna send a note to this Dr. Megan. We'll see if she answers. I never know, you know.
No, I'm so glad you did. This is great. And I so appreciate everything that you're doing. I think this is such a great channel, and you have so many different ways of talking about weight from, you know, personal experience, but also kind of what's going on with the news. And it's nice for people to have your channel as a source for that.
Oh, thank you.
Well, we publish every day, so it's this constant
That's amazing.
of how do you, you know, you do it twice a week. Well, the nice thing about the news is there's always new news.
That's
There's
true.
been a lot of news lately. A lot of news. So
That's true.
yeah, a lot to keep up with for sure.
But yeah, we've been chasing product reviews. Product reviews are crazy. There are so many things out there being manufactured right now, targeted at GLP-1 users, that some of it's just crap. Some of it's not too bad.
Yeah.
And I try everything, right? I've tried everything in the past to lose weight. So, you know, I'll try the protein shake and the bar and the chips and the cereal and the yogurt and the, you know, but
and I don't eat any of it.
yeah.
So they're like, what do you eat? I'm like, I eat real meat. I eat real vegetables.
Yeah.
I mean, you know, I like chewing, so I tend to go toward, you know, things that give me a lot of chews per calorie.
I love that.
So, but yeah, I'll try all the things.
I love that. That's great. I love the yogurt taste test. That's amazing.
Yeah. I mean, because I've been eating yogurt for years, right? I mean, I don't know, at least since the 90s. I mean, it was one of the things where Weight Watchers wanted you to get 2 servings of milk a day, and you could eat a yogurt instead of drinking a milk. And I'd rather chew or kind of chew a yogurt. Yeah. So I've kind of watched the yogurts evolve from this little section in the grocery store to the the huge monster it is now. And it's overwhelming to look at who can compare all these things in the grocery store at one time.
I know. I totally agree. Yeah. And the marketing does not help, because people, it's just like, it's hard. It is really hard.
Yeah. So anyway.
Well, very good. Well, if you guys would like to watch Megan's channel, please go and subscribe to Weight Medicine with Dr. Meghan, MD. She publishes twice a week. And if you want to see if you'd like her to be your life coach or your doctor, reach out to her at her website as well. I'll put the link in the description. Thank you for joining us, Dr. Meghan. It's been a great conversation.
Thank you so much for having me. It was really lovely to be here, and this was great.
All right. If you haven't already, please like and subscribe as well to the Downsized. And my name is Christopher Durham.
I'm Laraine Durham.
And we'll see you next time.